Nelson is a professor in implementation research at Linköping University, Sweden. He's also currently a visiting professor of the Jockey Club School of Public Health and Primary Care at the Chinese University of Hong Kong until 2022. There has been a delay for his visiting to us due to the COVID-19, so that we now start this webinar first online before he physically visits us. He was responsible for building a research program on implementation science at Linköping University. And as part of this program, he has developed master and doctoral level implementation courses, which have run annually since 2011. The PhD course is international and attracts students from all over the world. He leads several projects on implementation of evidence-based practices and policies in various settings, and his research also covers issues such as workplace learning, change responses, leadership, and professional culture in healthcare. He takes particular interest in issues concerning behavior and practice change, and the use of theories, models, and frameworks for improved understanding and explanation of implementation challenges. Nelson has interesting research background, including studies in behavioral economics with graduation from Stockholm School of Economics and systems development. Before he became a researcher in 2003, he had a 15-year career as organizational consultant in competence and development issues and as author of international books on artists such as David Bowie, Iggy Pop, and Prince. So let's welcome Professor Per Nilsen. Thank you.
Thank you very much. You can hear me?
Yes.
Okay, well. And I will then attempt to share the screen. Maybe that's it's. Can you see this?
Yes, very good.
Okay, then. Thank you. I was at Chinese University of Hong Kong in 2017, and I spent the semester there, and we did have quite a bit of discussions on implementation with Samuel's colleagues. And I understand that implementation issues have become more relevant as there is evidence for so many practices, interventions, etc., that the next step sort of is to study or facilitate the implementation and use of all these practices. So this is going to be an introduction to implementation science. Yes, first, see, I have to move that. So, okay, I'm from Linköping University. Linköping is Sweden's 5th biggest city. It's small compared to Hong Kong, but Sweden's total population is similar to Hong Kong's. But Sweden is sort of quite a widespread country. And this university is one of the larger in Sweden. Yeah, and maybe people probably know a bit about Sweden. It's in the northern part of Europe. It's usually quite cold now that I think Hong Kong, because we were in Hong Kong September to December, and I remember the weather being in September and October being really nice, and here it's autumn, getting colder, and soon there will be winter. And I had some figures connected to Sweden, some of the most well-known, I guess, but actually Volvo is nowadays owned by a Chinese manufacturer. So not all of these are Swedish, although I guess IKEA is quite big in Hong Kong too. And yeah, Spotify is a Swedish, is strong on IT and technical innovations. Now it says unstable connection. I hope it doesn't continue. So what I will talk about is briefly, I mean, what is implementation? What do we mean by that? And what is implementation science, the research we do on implementation? And how did this research come about? What is the sources of it? And then, which I think many, at least here, healthcare practitioners ask us, so how do we succeed with implementation? And I usually say there is not a single factor which guarantees successful implementation. Rather, it's different, what we call determinants, which I will get to. And then some thoughts on how implementation science can be used in practice, which I think is quite important because this whole field is based on the challenges of getting research into practice. So then we would also like this type of research to have an influence on practice. So, and I think the plan was that I go for like 40 minutes before a break. And most of the content I will be talking about is in this book, which I think Chinese University of Hong Kong has it's available through subscription or something. So what is implementation and what is implementation science? It's not really rocket science. It's quite sort of applied research. I mean, if you take the term implere, it means fill up or complete. So it seems like implementation is sort of the final stage of a process that is completed with the implementation. And in everyday talk, we might use different terms like introducing or put into effect, etc. And it's definitely not something new, because mankind has always had these ambitions, which it has sought to make a reality, sort of translating ambitions into reality. And often, and this middle is what we will talk more about, evidence-based medicine or evidence-based practice. But here are also implementation issues. How long does it take from developing these vaccines to their practice or their use in healthcare? And it's obvious that it can take quite the time from development to implementation or use differs quite a bit. And we'll talk more about that, why it might differ so much. So to clarify implementation research, the focus, I've put together this picture, because if we start here, developing knowledge, research, evidence, and if we're talking implementation in healthcare, which this lecture mostly concerns. We have this sort of middle, what did I call it? Is a missing link, or it's the link between the research and its benefit for patients and populations. So implementation research has its focus on this area because clinical outcomes. Yeah, and I think making it sort of up to date, we can see that the vaccine, it's the same. It's an implementation issue. Getting the vaccine into healthcare and being able to vaccinate populations is essentially, it can be seen as an implementation challenge. But as I addressed, it has been an unusually quick implementation process compared to the sort of cliche that we say that it takes 17 years from research to practice, which is a huge simplification, and yeah, it's not always like that. So if we want to understand what implementation research is, I think this paper made a good point. The goal is not to establish health outcomes or health impact, but rather to investigate what influences the uptake of various practices, interventions, methods into routine use. So it has a different aim. So this picture just illustrates that the focus is not here. The focus is on the link. And this paper also, I think, addresses the fact that this type of research and practice is quite complex, challenging, because there are so many factors involved. It's not just the health outcome, it's provider, organization, and policy levels of healthcare that influence the implementation. So it's, I'd call it multifactorial. There is not a simple or one single factor which determines implementation success. Yeah, and this shows that if clinical research has its focus on individual patients, here we have to address staff, teams, the whole organization, the community and policy levels. So that makes it multi-level and implied in that quite difficult. Because if you want to affect or influence the individual provider, there are many levels of influence. And defining this field, which is quite young, this first journal and definition came in 2006, only 15 years ago. And yeah, it's the scientific study of methods to promote the systematic uptake of research findings, etc. So I think here it's the key is, I think methods we would these days call strategies or interventions or support facilitation to promote the systematic uptake. So this definition sort of assumes that evidence will not be adopted or taken up unless we use strategies or methods to promote this. It's sort of based on the recognition that evidence does not really spread or spread by itself. There is a need to support evidence uptake. And we talk a lot about this gap, and there were quite a few pictures of that on the internet. And it seems to me, which I think is a bit bothering, that it's sort of academia which is not taken up, and sort of the assumption might be that is the practitioners, it's the healthcare which does not adopt or take this up. So who is responsible for the gap? I think researchers seem to convey that it's the practitioners. Why don't they adopt this new approach to providing alcohol prevention or whatever? But I usually say that it's equally researchers to blame, because many research studies are done in such a way that the findings are difficult to implement. For example, conducting RCTs with, for example, training for the healthcare providers involved in the trial, and various forms of support, which might not be implementable after this study. So I think doing controlled research studies, they have their relevance to show that something might work under ideal circumstances. But healthcare is rarely provided under such perfect circumstances. So I think we have to meet halfway. Research also has to be aligned with or adjusted to how healthcare practice is functioning. So it's not only about achieving evidence-based practice. I think developing practice-based evidence based on how practice is working. I would call that a more bottom-up approach, I think is very important. But that often implies a different type of study. You might not be able to do RCTs, etc. So this is a challenge to develop and do research that is more relevant for healthcare practice. So the origins is the evidence-based movement, which was described first in 1992, 30 years ago, and I think it was sort of developed 96. There was a further description, but it sort of developed based on the notion that scientific findings should be more widely and comprehensively implemented within typical healthcare practice. So when the evidence-based movement gathered momentum, implementation in its wake. And possibly this is a a bit of an exaggeration, but I'm sure I still think that's the case, actually, that sort of evidence, it should be self-evident that if it is an evidence-based method intervention, it should be adopted and spread. But that's not the case, and that provides a rationale for implementation studies to understand why this is not the case. So you could say that the science has arisen due to failures, that the implementation is not implemented to the extent it might be expected. And I think this was described first in 1996, sort of an attempt to broaden the definition of evidence-based medicine. We now talked about evidence-based practice, and EBP could apply to many areas of society. There's even research on evidence-based management and evidence-based policy. And it's based on 3 types of knowledge. The clinical experience, if you're talking healthcare, is one component, ingredient. And the other is patient preferences. We are talking a great deal about patient-centered care or person-centered care, sort of a trend towards at least ambitions to involve patients more in the care and treatment. But then what was sort of a new component here with the EBP and EBM, the research. And this was presented as a new approach to healthcare. And I think that's sort of taking credit a bit too much, because I think healthcare has always, and any other practice for that matter, used based on experience and other knowledge, research, but also to different levels of involvement, also patients. But the new thing here was that research evidence was given a much more, a stronger emphasis. And this is another, there are many ways to show this. And I think communicate things, but they also simplify matters, because if you take this picture, if patient values go against the best scientific evidence, we have done studies on, for example, in physiotherapy, where patients might have the impression that they should rest if they have a back injury or something, whereas best scientific, most updated evidence might probably suggest that you need to be mobile and at least have some physical activity. You have a sort of a dilemma which should be given the patient values. And we also have clinical experience, which oftentimes is good, but there might also be clinical experience in the form of habits, where you sort of stick to a way of working which has worked well in the past, but which might become outdated as new evidence comes along. So I think these figures show, maybe an ideal that you can balance these three types of knowledge. And implementation then is about implement. And what are we implementing? You can call it an implementation object, although this object is usually a practice. And yeah, it might be CBT, which there is evidence for in many circumstances, and motivational interviewing or hand washing. So these are practices for which there is evidence in the form of empirical studies showing that there is efficacy or effectiveness. Efficacy is usually evidence under more controlled circumstances, where everything is sort of set up to test, does this work or not? Whereas effectiveness is more intended to be more similar to routine practice conditions, even though as I mentioned, oftentimes think that it's still quite far removed from how practice works. So to summarize a bit on the roots on what we today call implementation science or implementation research, and I think you could go back quite far, because Rogers talked about how innovations diffuse or are spread, and he talked about some sort of attributes or characteristics of the innovations that facilitate their spread. For example, perceived relative advantage is the new way of working, the innovation, perceived to be having advantages compared to the previous way of working, then it is more easily spread and implemented. And his theory on the diffusion of innovation still is still very much applicable. And then in the 70s, we had research on policy implementation. Oftentimes, governments' policies on how to combat poverty or something. And this was also, I think they actually introduced the term implementation. But this research sort of, it was not focused on healthcare, it was more societal issues. In the 70s and 80s, nursing research started looking at how nurses used research in their daily work. I think that's very close to, and actually these days, a part of implementation research. And then we had the EBM, evidence-based medicine and evidence-based practice, first time described in 92. And in this century, implementation science has emerged, and all these different variations. And I think it's quite difficult to keep track of, and even actually quite pointless, because I think all these terms overlap. So it's better to talk about implementation research or implementation science. But some talk about knowledge translation, for example. And yes, this is a growing field. And as I've been in a few other fields before, like injury prevention, for example, or alcohol prevention, and I've checked similar statistics for other fields, and some of them, for example, injury prevention is almost stagnating. So I think this sort of almost exponential curve increase is unusual and shows that implementation research has gained, it has been recognized as an important field. The question is, the future of the development, because as I think we have recognized many challenges with implementation and problems, and I think many assume that this field could sort of solve them. And I think research, of course, can solve some problems, but this is more social science, and there will be many factors influencing. So I think we can accumulate knowledge, but there might be sort of, in the long run, I think it will level off a bit because of the recognition that maybe some key problems are not that easily solved. Maybe that sounds pessimistic, but I think there is a sort of a youthful enthusiasm in the field, which is good, and I think it's innovative in many ways, research in this field. But we will see how it develops. And this is the leading journal, and I think it's a journal that's been important for the field. It started in 2006, and this curve is how many papers, articles they have received from researchers, and this is how many have been published, and it sort of shows that it's so much more difficult now to be published than in the early stages. And it also shows the increased interest in the field. And thankfully enough, there have come, of course, and supply, because there's emerged further implementation journals in just a few years ago. But they're also possible to publish in many different journals, because implementation is sort of a cross-boundary type topic, which could apply to lifestyle studies or injury prevention or whatever, e-health. So research is also published in a broad set of journals. And as I said, there are many different names for essentially the same thing. And I think we should take, maybe I'm a few minutes early, but if we take a 10-minute break, I will then go on to talking about what determines implementation success, and also we will have a Q&A towards the end. So I think we should take a break to what's that, in 7:45. Is that okay, Nelly?
Yeah, sure. So we'll take a break now. Please come back in 10 minutes, everyone. Thank you. Yep, I'll share the intermission screen to everyone now. Yep.
I think this is it. Okay. Is this is it? You can see this now?
Yep.
Yep.
Okay. Good. Okay. So what determines implementation success? And this is how we often convey or describe the 17-year odyssey from starting, prioritizing research until practice, and the implementation challenge is primarily this final section here. But then we have the vaccine as an example. Quickly it went from the first stages to implementation. So I think this is a key question. Why does it sometimes take 17 years from research to practice, but other times 1 or 2 years? And there is not a single or simple answer to that. But the way we first have to address what is implementation success. And we usually talk about adoption or uptake, the intention or decision or action to actually start using a practice. And this evidence practice might then be, for example, the vaccine or any empirically founded, based on research, practice, interventions, services, programs. And this is a way to illustrate the complexity, even though as any model, this is also a simplification to show a number of key determinants. It's based on several similar frameworks. So based on research, we know that the implementation success, if it goes quickly or if it takes a long time, will depend on these determinants and also the interaction between them. So what is being implemented, the implementation object, is obviously one aspect. And here we often use Rogers' innovation attributes. If there is a perceived relative advantage, and of course, for example, the vaccine, it's quite clear from the studies, there is an advantage compared to not taking the vaccine. But the perceived relative advantage might not be as obvious for many interventions in healthcare, because implementing something new usually means you have to learn this new approach, and you might be an expert with long experience in an existing method. So relative advantage is not always so obvious. And also the perceived need is something. Is there perceived need for this object, this practice? Not always the case. And then we have here the strategies, and that's what I was referring to when I talked about the definition of the implementation science. There's recognition of the need for some sort of support to facilitate the implementation. And then we have the adopters, users, practitioners in healthcare. If we talk about the implementation science applied to healthcare, they have their attitudes and motivation and beliefs, which might not be sort of aligned with the new practice. And also we all have our habits, our ways of working, which we usually are quite efficient in. So it's not always a given that new evidence-based practices are welcomed with open arms.
Sorry, Per, can you, your slides are not running. Can you share using the slideshow?
Okay.
Yeah.
It says you are screen sharing.
But it seems like we're seeing the same slides. On slide 27. Is it supposed to be running or?
Okay, now it should be slide 31.
Yeah, so can you, is it a slideshow? You should run as a slideshow, and because it stopped at 27.
Yeah, but that's
or maybe you can share the screen again and tap the PowerPoint once again.
Yeah, I say stop share, and then I
Yep, thank you very much.
go for share screen, and then I take. Do you see now?
It's still the slide 27.
This is what determines implementation success.
Yes.
And you can see now that it's moving ahead.
No, can you go to the next slide?
Because this is, yeah, I'm pressing for the next slide.
No, we couldn't see it. It's not moving.
Okay.
Or do you need me to?
Oh, now it's moving.
It's at 28 now.
You can see the 17-year Odyssey.
Yes, that's right.
Okay, I've been talking about that before, but, and you can see, can you see this question here?
Yes.
Okay, then it seems to be working then.
Is it full screen or?
This is a full screen.
This is a full screen. We didn't see it as full screen. It looks like a slide. Doesn't look like a full screen.
But maybe Nelly, because I sent you the.
Yeah, I can do it. Please
I say stop from here.
Please wait for a moment.
I thought you, I mean.
Yep. I'm
having used Zoom for a year and a half now. It should be. Yeah, I can see.
Yep. So
okay then.
Yeah,
I can.
The new slide.
Yeah, I think we can move past this because that's only to set up for the next slide question. Yeah, you can. The next slide.
Oh yeah.
Okay. So this is the key question here. Why does it sometimes take so long, and why could it other times be a very quick implementation, spread and implementation? Okay, next slide. And you have to one more. Yeah. So adoption, when we talk about the implementation success, that something has been adopted or taken up in practice. Okay, next. Yeah, this is the sort of framework we use, showing the key determinants or the key factors in influencing implementation. And I think I talked about the implementation object, the way it is perceived. Does it respond to a perceived need? Is it perceived as having an advantage compared to previous practice? And then here we have, in the bottom left, strategies, which ties in with the definition of the field that there is almost a necessity for some sort of strategy to support the implementation. And then we have adopters, users, practitioners who might believe that this practice being implemented is a good thing. It's something that complements and enhances their practice, but they might also be resistant to the implementation. And then we have this really challenging aspect, the context, because you might succeed with the implementation in one hospital, and it might meet resistance in another, even though it's the same intervention, for example. So the context is always playing tricks that, and that's one reason why it's difficult to say that this is always working. It worked here, but it might not work in another setting. Okay, next. Yeah, I think this is my sort of case study. It's about brief alcohol intervention, usually delivered in primary care. And there's been 4 decades of research, and it's still not widely used in healthcare. At least here in Europe, patients are not regularly asked about their alcohol consumption. And there is overwhelming evidence for the effectiveness of these brief interventions. But still, after so many years of research, it has not been implemented. And this obviously begs the question, why? So next slide. And then you can, and this is the outcome, which we just state that it's a lack of widespread adoption in healthcare. So why is that? I can press the next. So the implementation object might be one aspect to blame. It is often perceived as complex, and it might not be compatible with existing routines. And it's not seen as being a relative advantage. Yes, and then we have the strategies. Oftentimes some sort of training and learning about risky drinking and its consequences. And there's research, inconsistent finding regarding how effective these strategies are. We have guidelines in Sweden. There has been financial incentive to get more physicians to address alcohol. Okay, next. And then we have all of these factors which might be attributable to the adopters, the healthcare practitioners. Some say they lack knowledge about the early symptoms of problematic alcohol. Lack confidence in how to intervene, and resistance to raising the issue. It might be seen as sensitive. Okay, and then we have the context, usually not considered part of the professional role. A lack of leadership support. It might not be a highly prioritized area of healthcare. Lack of resources, lack of training, etc. So all in all, next slide. I think we can move back maybe. One more. So this is one way when we communicate and we get asked from healthcare practitioners what is the most important aspect? Well, how do we succeed with the implementation? How do we make it happen? And this is one way to respond to that it's multifactorial. In some cases, it might be that the implementation object is perceived as being too complex. Otherwise, it might be strategies being ineffective, etc., etc. So this is one way to reflect and possibly also study various reasons for lack of or success as regards implementation. And the different domains or determinants are quite similar in many other similar frameworks. So it seems to be sort of the quite a bit of consensus that these are the key factors in succeeding with implementation. Okay, then not so many more slides. I think it's important to recognize that the implementation of new practices or changing practices, which is usually needed, tends to be challenging because we all have our habits which make us effective, efficient. There are established routines, pathways, and there are also collective level influences from your profession, from your colleagues, from the managers. So there are many factors at play beyond the individual's attitudes or beliefs or motivations. I think sometimes this research has focused too much on the individual decision-making, sort of not recognizing that this decision-making has many influences. But if we are to summarize, what does successful implementation require or depend on? Yeah, there are numerous determinants, and we call them barriers and facilitators. And there is interaction among various determinants. So it might be that two seemingly unimportant factors could together become a very strong determinant. So you have to account for the combinations, which makes it quite difficult because you cannot isolate and say that the providers are more important than the strategies, because it depends a great deal on the combination of determinants. And there are multiple levels. This is also a huge challenge, because even if an individual practitioner might be very much in favor of a new intervention, he might not have support at a higher level. So we have to look at different levels of healthcare. Yeah, and it depends on effective strategies. And it's sort of a complete subfield here, investigating different strategies. And I think sort of a general conclusion is that there are many strategies, but few are proven to be consistently effective. So there are challenges, and implementation remains often a challenge, but it's worth considering why the vaccine was such a success story. And reflecting on that, I think we will have that in a workshop in a couple of weeks. You can use this pyramid to discuss what might have been different. For example, government support, strategy, so much resources, etc. So, but that's how this pyramid can be used, and I think it's a tool to reflect on what might go wrong or what might be very important when something is to be implemented. So, to summarize, implementation science can provide some knowledge for understanding the challenges of implementation, but also for planning implementation, because there are many models showing a number of steps, which usually have been shown to be important to take in a number of activities. Usually a lesson learned is that implementation has to be planned carefully quite early. Unfortunately, there are few quick fixes, not new, but still important to recognize. And there are a few success factors that always work. And I guess that ends this part, but I'd be happy to take questions. I think we maybe have something in the chat. Yeah, I hope.
Yep.
The slides.
The first question is someone asking whether you have a book to recommend on implementation science.
Yeah, that's the book I showed at one of the early slides. I hate to. I mean, it's impolite to recommend one's own book, but
it's okay.
The book, that we have really we included so many different many researchers from the field. Yeah.
And that is by you and Professor Birkin.
Yeah, and I think it covers. We approached many of what we considered the leading experts. For example, some was an expert on implementation strategies and etc. So, and most, I guess all actually were quite willing to participate because, but unfortunately that book is extremely expensive, I've seen, because Elgar Publishing has that policy. We didn't recognize that until quite late actually. But I think you have an e-license or something, so that you can access it. I think Vincent knows about that.
Yes, it is available for all the CUHK staff and students through the library website for free.
Mm-hmm.
My question, I have a questions I'd like to ask is, you're finding the determinants of implementation and what are the factors that might be barriers for implementation, but sometimes finding the answer doesn't mean you can implement afterwards. So in your experience, have you seen a lot of changes usually after people doing implementation research on intervention? What does it usually come out in the end?
I think the more, identifying barriers and facilitators, that should be the sort of the basis for, you should design a strategy which addresses these. And I think those who have been most successful has been projects where they have used actual facilitators. Some researchers have sort of combined the role as researchers and practitioners. But sometimes I think that you get results as long as the study is ongoing. But what happens when the researchers leave? But I think if the knowledge level, and there's been some research in parts of Africa, for example, where it's obvious that more knowledge will make healthcare more evidence-based practice. I think they've had really good results. But it's a good question, because I think many times the effects are quite small. That's sort of a pessimistic outlook, but I still think with resources, etc., you can get results.
Okay. Any other questions from the audience? what would be, I'd like to follow the next question. What would be the current interest for people submitting to the implementation science journal? Are there any topical areas that the journal would be interested in, or what is the hot topics?
I think empirical studies, I think they are very focused on. So I mean, is large, sort of, if you do interviews, you have to do many interviews, and RCTs, they are sort of a bit in a medical paradigm. But empirical studies, well-designed studies, I think they have good chances of being published. Less so if you do something on a concept or something more theoretical. They seem to think that we've had enough of that, and to some extent, I can agree with that. We need more studies to show that you can hopefully influence practice.
That's a good news to know, because I've been reading a lot of the theories behind many of the papers. And it would be interesting to look at more of the interventional studies. I was reading on some of the journals saying that many of the apps that we use on iPhones, out of the 100 apps that is developed, for example, for mental health or for, it's only about 1% being used continuously. Is this an area that is worth exploring further?
I think e-health is huge. Various e-health applications, how you implement them in healthcare, I think that's very much a growing area. And artificial intelligence, all these, because I guess in the whole world now, we need more self-management. We need sort of people not coming to healthcare, because healthcare is going to be overloaded with older people with complex needs. So I think self-management, using e-health technology to monitor, etc., is a huge coming field. And I'm sure it's going to be similar in Hong Kong, with a large old elderly population, which will require more healthcare, and others possibly being able to self-manage more.
I see.
So I think there are many, challenges for healthcare, and I think technology is perceived as one solution.
Okay. So if there's other questions from the audience, Professor Vincent Zhong.
Hi, I have a question for you. So you're just mentioning that actually the journals are now more interested in looking at, okay, what sort of empirical evidence we have with regards to different interventions that promote the uptake of evidence, and of course implementation of evidence-based interventions and guidelines. So what would be your recommendations for newcomers in the field in developing context-relevant implementation strategies? Because we may have the diagnosis done in that context, we know what the facilitators are, we know what the barriers are. Then how do we move on to actually develop a program of implementation strategies together with probably the frontline healthcare professionals? What would be your recommendation?
Yeah, my recommendation is that I think that's one of the key challenges, going from identifying barriers and maybe facilitators, but what strategies are implied. I mean, if it's a lack of knowledge, yeah, obviously you can maybe a course or something to convey knowledge, information. But if it's a man's resistance, what is then the strategy? I think the behavior change wheel, this is a Mickey's work. They have at least tried to sort of combine, I call the first part to understand the problem, and the intervention and strategies is the solution. But matching these is difficult. And I think, I mean, using experience is one way. I think also talking to stakeholders, more sort of, we call it co-production or co-creation, might be one way. But maybe also look at behavior change wheel in that's part of in a chapter in the book. But I agree, that's a huge, going from a problem, understanding of a problem, to what are the solutions is difficult. And I think usually when I hear political debates on TV, it seems like politicians, I mean, they describe the problem differently, and they all have their own solutions, but nothing is really evidence-based. It's usually their interpretation or subjective point of view. And I think we hopefully can be more objective, but it's a challenge.
I do agree.
Yeah.
Yeah, I do agree this is a challenge, because let's say if I evaluate a particular strategies, let's say to promote screening and brief intervention for alcohol misuse in Sweden, and the strategy may not be transferable to context in Hong Kong, because we have very different organizations responsible for delivering the intervention, and the health system financing and organizations very different as well. That's why I think this is quite an important area we need to look at. And I do agree that this is where you need theories, because individual trials done in different places, they may have their own issues and practicalities. But if we can generalize to a theoretical level, then other health systems may actually learn from the experience through the application of relevant theories.
Yeah, I agree. I mean, the context might be very different. But I always think we need theories when we are investigating what is essentially some sort of change, because we need to understand how this change came about, or if it did not come about. So we need to either use existing theories, or, which I also advocate, use logic models or our own program theories, at least something to make explicit how we believed or argued that this would work, because then we can examine that and see, okay, it might have been this step which didn't work. So I agree. And I think implementation, even though we talk about implementation of evidence-based practice, I think what we are trying to implement are changes.
So
and change is difficult for, I think, human beings. We sort of need to balance change with stability. And I think I'm sure we researchers are not always so willing to change. So why should healthcare practitioners be very glad at every our suggestions how they should change? I think it's a fundamental challenge there.
True. So for the audience who's interested in the use of theories, I think Professor Nilsen is going to have another talk with us next week, and we'll concentrate a bit more on the use of theories and different approaches to understand the development of implementation science strategies using theories, and also, of course, the use of theories for diagnosing issues. I believe that there's still more questions, right, Professor Wang, from the audience?
I think we have answered all the questions so far.
Okay, so I do see one more question from Professor Popun, and she's asking if, do you think if support from the managerial level from the front line is more important in the implementation science?
But I didn't hear that.
Okay, so the final question is...
Can I read the question, or?
Yeah. Do you think if support from the managerial level or from the front line is more important in implementation? So the top or the bottom is the more important?
I think management support is extremely important, and I think maybe that's one area. I think organizational research might know more than, because implementation science is sort of a bit like public health. We sort of use theories from different areas, but there might be experts on organizational theory that knows that nothing much happens unless management is on board. So, I mean, it's difficult to sort of compare the importance, but in general, I think management and also leadership, because you don't have to be a manager to be a leader, an informal leader. In Sweden, we say that nothing much happens unless the physicians are on board, because they are often informal leaders. So leadership and management, I'd say, are extremely important on average, sort of.
Okay, there's another question. This seems implementation science is suitable for using RCT study design. Does cross-sectional study have the potential?
Yes, but if we want to document change and then sort of causal, if you want to do an intervention study, I would say that we need the cross-sectional. You can only arrive at associations, but there are many studies, cross-sectional studies, but I mean, you cannot draw any firm conclusions as to the cause and effect. But RCT studies, we often do cluster RCTs because it might be different primary care units that you can randomize. And the problem then is that you hardly can randomize thousands of units. It would be smaller studies if that is the analytical level. But cross-sectional studies are definitely done. I mean, we examine the extent to attitudes, beliefs to using research in, I think it was rehabilitation, rheumatology. And that was based on a questionnaire. So it was a cross-sectional study. But I guess, I mean, RCTs, if you want to prove an intervention's effectiveness, that is, yeah, it's the gold standard. But I think what we're missing then is usually the contextual influences.
Okay, so probably the last question is, usually we will find a lot of determinants, and so the question is how to prioritize the determinants that should be addressed, and what or who would be the key role to lead changes according to your experience?
Yeah, that's tricky. I think here we have a sort of it's promoted increasingly that we should co-produce, that we should engage with stakeholders, that they have their say. But then the challenge might be that researchers might know that a certain determinant is less important or something. So, but I think in getting more perspectives, because I think we all come with our biases and sort of preconceived notions about what is most important and how we should change things. So I think getting more perspectives is one way to prioritize reflection. But yeah, I don't have any simple answers, because this is more social science. Everything is connected, but yeah.
Okay, so since we have answered all the questions and it's approaching 8:30 here, and I believe we almost at the end of the presentation and Q&A sessions. So I want to thank Professor Nilsen again for spending time with us today, and there will be another workshop next week. So I'll leave it to Natalie to close.
So thank you, Professor Nilsen and Professor Wong. This is the end of our first of the 2 episodes of Implementation Science webinar. So we're having the next webinar on the next Thursday on the 11th of November. So if you did not register the second and want to join, please go to link in the chat box. And this is the evaluation time. So please see here the evaluation link. And would love to hear your feedback to have a better webinar next time. So please scan the QR code here or go to the link in the chat box as well. For doctors going to claim the CMD points, please you have to finish the evaluation form in order to, as a proof to claim the CMD points. And so the school is hosting a series of upcoming events, including webinars and other on different topics. So please follow our social media on Facebook and LinkedIn, etc. And thank you. You may
thank
do
you.
your
Bye-bye.
evaluation now. Thank you.
Thank you.
And thank you, Professor Nilsen, really. See you next Monday, see you next Thursday. Thank
Bye.
you.
Thank you. Bye-bye.
Bye-bye.